Welcome everyone. This is Dr. Sharad Jaitly from New York. I'm your cardiologist and thank you for visiting MuniMeterHealth.com, your favorite website, which is dedicated to educating you everything about the human heart and its illnesses. So thank you again for being on MuniMeterHealth.com. I appreciate your enthusiastic support in our endeavors to spread the knowledge freely to all about the human heart and its illnesses. We are, as you know, on Facebook and YouTube. Those are our two video channels. Hope you're watching on either of them, perhaps on both of them, which will be wonderful. Without any further ado, as I always say, let's delve into the matter of the video today. The subject of the matter today being, what are the surgical options and indications in an ASD? Now, I know I've done a couple of videos earlier, I believe, and you can just browse by in other videos as well to see, refreshing what an ASD is. We know that ASDs are four types. Atrial septal defect, which is a congenital defect where the child is born. It could be an ostium primum defect. It could be an ostium secundum defect, which is more common. And then you have the sinus venosus and the coronary sinus defects. So these are the four defects that can occur, but ostium secundum is the prototype, if you will, and we tend to discuss that more thoroughly here because that's the commonest. 80 to 85% of the ASDs are ostium secundum. Now, invariably, let's look at the pathophysiology quickly by looking at this schematic that I normally draw for you. Here's your four-chambered heart. The right side obviously is here, and this is your left side for the sake of the students and refreshing. Here is your tricuspid valve, if you will, and this is your mitral valve. Here comes your aortic outflow tract, and this is your pulmonary outflow tract. So looking at the perspective, this is where the defect is. Now, if you will, the ASD defect is normally, as I said, if it is asymptomatic, it may not be detected for a longer time, especially the smaller defects. But the larger the defect, the more is the volume flowing from left to right. Remember, there is a left to right shunt that is the determining factor as to what the clinical features would be and when would you be offering the surgical therapy, if any. So most of the times the patients will present with exercise intolerance, and obviously those are your typical clinical features. Dyspnea on exertion, as we call it, DOE. And then patients may have palpitations, which is very common because of the right atrium and left atrium both being enlarged. One can get atrial flutter, atrial fibrillation, and then of course a lot of APCs, and there will be SVTs as well. So supraventricular arrhythmias are very, very common in this setting of ASD, implying that there are increased pressures in the left atrium as well as in right atrium. However, what determines the surgery, or what the determining points for surgery are, is the volume of flow that occurs and the amount of pulmonary volume overload that occurs here in the right ventricle, and subsequently what are the effects on the pulmonary vasculature. So those are your hemodynamics that you really want to base your surgical options on. So let's understand quickly what the other rest of the clinical features would be like. There would be a wide fixed second sound, which is the hallmark of, as I say, diagnosing ASD. If that's on the boards, by the way, you've clinched the diagnosis. They want to imply that you're dealing with an ASD case. Remember, if they show a wide fixed sound, but it's not always present though. That's the key. You have a right bundle on an EKG. You have signs of right ventricular heave, if you will, and pulmonary arterial vasculature can be palpated in the second left intercostal space. Also, you can feel the sounds because of the P2 being loud, so one can feel that diastolic sound. So some of these are the features here, and then of course, as I said, dyspnea and exertion. Syncope is very rare, and rarely one can also see the stroke as the first manifestation. Unfortunately, a CVA or a TIA, if you will. Those are the other features that can occur, and it's because of the paradoxical embolism that can occur from left to right, and then one can have initially from when you develop a right to left shunt, that's when the TIA or CVA can occur because of the right to left paradoxical embolism. Now, it's also very important for us to know what type of procedures or surgical options are available. Well, the surgical options are, if I say, one would be a device, and we call it a device closure, if you will. I'm writing a little fast here for you guys. Maybe we want to save the time quickly on the video time. Device closure, and the other one is obviously a patch, and the patch could be either from the pericardium of the individual, or it may be a synthetic patch, and synthetic Dacron patch as they call it. So either of those two are the norms. So having said that, then we see the following. I would say we like to see the QP-QS ratio. Now remember, the ratio, if it is less than 1.5, then no surgery in an ASD setting unless the patient is symptomatic and unless the patient has had an episode of CVA. If there is an episode of CVA or a TIA, then you go ahead and do the surgery. But if it's less than 1.5, the QP-QS ratio. Now, by the way, what is QP-QS ratio? Just to refresh it for the students and interns and residents. QP is the volume of flow that's occurring in the pulmonary circuit, and QS is the systemic flow. So the ratio, it's a ratio between the pulmonary and the systemic flow, which is calculated either by echocardiography or by right heart catheterization, preferably right heart because that's more accurate. Then you can also get the resistance. So if the ratio is less than 1.5 to 1, then you don't operate. Now the ratio, if it is more than 1.5, then you operate this patient anyhow. And you could choose either. Now remember, all these procedures, the device and the patch, the device is only available for the ostium secundum variety, remember. It's not available for the other three variety, the ostium primum and the sinus venosus and the coronary sinus variety. So the ostium secundum, the device is available. Now you have to have these patients on aspirin at least for 3 to 6 months post-op to prevent any further embolization and clotting, etc., etc. But endocarditis prophylaxis will have to be given for the device as well as for the patch anyway, post-operatively each time they go for a dental procedure. Now, if the ratio is more than 2.0, which is very, very rare in adult, because most of the time the ratios are, if 2.0, these are in very, very young children and infants, and they have clinical symptoms of heart murmurs, they have clinical symptoms of failure to thrive, and they're diagnosed very early and the ASD is closed. So remember that it's very rare to find a ratio more than 2, but more than 1.5 is customary on the boards and of course clinically as well, to go ahead and operate and give a device. Device is normally given via fluoroscopy and by a transesophageal echo guidance. And under the transesophageal guidance and the fluoroscopy, one can apply the patch here, deploy the device is deployed on the left side of the interatrial defect. Now, there are certain criteria for the defects. Remember, the defect cannot be large enough beyond 41 millimeters. That's the criteria. The maximum you can go is up to 41 or 40 millimeters, if you will, and it should have enough rim of interatrial septum still around so that the device can be applied. So imagine an umbrella going through this hole, and then on the left side, that's where you deploy it, and then the umbrella gets closed and you pull out the catheter. So when the umbrella is closed, this device gets attached automatically and snugly fits onto this rim from the left side like this, if you will. So these are criteria. You should have enough rim to really attach on, and the largest size that you can really take is the 41 millimeters only, and that has been determined by the companies that are marketing the device and or by previous clinical trials. So having said that, about the device, let's look at the patch. The patches, as I said, they are the pericardial and the synthetic variety. And normally they also, you can also do a primary suture first. A primary suture may actually avoid any patches, but see if the defect is small enough, or if it's other size at other sites like sinus venosus or say an ostium primum defect, then you can just close it by primary sutures. But if not, then you end up putting a patch anyway. And again, endocarditis prophylaxis and embolization prophylaxis must be done with an aspirin for 6 months, and then endocarditis prophylaxis indefinitely for any dental or GU or GI procedures. Now, this is in a nutshell the surgical management of ASD, and hope you enjoyed the discussion on this video. Hope to see you again in my next video vignette. Thank you for watching MuniMeterHealth.com, your favorite website. Until then, so long. This is Dr. Sharad Jaitly.